Our next speaker is Roach. She is the chair of Healthcare for All Minnesota and national coordinator for the labor campaign for single payer. You may know that Rose recently retired as the executive director of the Minnesota Nurses Association after 34 years in the labor movement, having represented public school employees, both here in her home state of Minnesota and in California before being hired by the MNA in 2014. For 2 decades, Rose has been involved in the healthcare justice movement as a trainer and national speaker with elected officials to craft legislation that moves us to a patient-provider-centered healthcare system. What a concept. So, Rose, do you want to come up? And Rose is going to tell you, let me see here, how managed care has failed us. It's a very important thing to start understanding what this deal is with managed care.
All right. Yeah. Woohoo. Thank you. Good afternoon, fellow patients. I bring you greetings of health and joy. So, July 30th, 1965, a truly historic day that created one of the greatest social safety net programs ever enacted in this country. But as is the case with almost everything public, the privatizers have been working hard these past 58 years to turn our public health programs into cash cows for the medical industrial complex, which includes insurance companies, yes, but also big pharma, prescription benefit managers, gigantic corporate health systems, and any number of cottage industries that stand between us and our doctors and nurses. If you're wondering what I mean by that, let's take a look at some recent headlines and see if we can get an insight into what's happening within our health system. Here's one. Health insurers have spent over $141 billion buying back their own shares since 2007, while premiums and deductibles have skyrocketed. Top 5 largest U.S. pharma firms' net earnings topped $81.9 billion last year. For private equity firms, dropping ER docs is a simple equation. Well, maybe not so much for us as patients, eh? They could have qualified for charity care, but Mayo Clinic sued them. Allina cuts care for patients who owe. Doctors at $4 billion nonprofit are not allowed to see poor adults or children with too many unpaid medical bills. Medicare Advantage was meant to curb federal health care spending. It's costing more instead. The cash monster was insatiable, how insurers exploited Medicare for billions. Medicare Advantage plans often deny needed care, federal report finds. Major insurers are scamming billions from Medicare, whistleblowers say. Deceptive marketing practices flourish in Medicare Advantage. That sounds more like a healthcare marketplace than it does a healthcare system. How have we gotten here? To this place where health is treated like a commodity, as if health can be bought and sold and fits within the confines of the economic theory of supply and demand. Healthcare isn't a consumable good. If we learned nothing else from the horrors of the COVID-19 pandemic, we learned that health is indeed a public good, and the insulting question of who deserves healthcare was definitively answered. We all do, because we're human, and it's just that simple. Many health economists hold to the idea that excessive health care costs in the U.S. are due to 2 things: physician greed and patients getting too much care. We're overusing our health care. This theory is that a system that pays for care based on receiving a fee for the service that's provided is the reason health care costs so much. So their solution to fixing that system is to squeeze physicians and then to squeeze the patients. To squeeze physicians, they recommend shifting the insurance risk to the doctors and hospitals, holding doctors accountable for the cost of care, and giving them a set dollar amount for certain population of patients, and limiting access to that care through the use of networks, and then creating these HMOs and ACOs and MCOs, and I say EIEIOs, right? None of which are really getting us the health care we need. Then you squeeze the patients, and you make them stop getting so much health care. You increase deductibles and copays and co-insurance. You underinsure them. You make them choose between a whole pill and a half a pill, 3 meals a day or 2. And this is how the U.S. uses market forces to control prices. These are not healthcare strategies. These are business strategies, right? But Minnesota insurance companies were quick to jump on this theory of overuse and fee-for-service bandwagon stuff, and that has resulted in the market-based healthcare business model madness that's been thriving here in Minnesota since the early 1970s. Managed care ideology has also caused consolidation and merger frenzy, gigantism within all sectors of healthcare, none of which is bringing down the cost of care. As hospitals began engaging in merger mania, the results again translated into higher prices. The Robert Wood Johnson Foundation report, The Impact of Hospital Consolidation in 2012, found that, quote, hospital consolidation generally results in high prices. When hospitals merge in already concentrated markets, the price increase can be dramatic, often exceeding 20%, unquote. Let's take a moment now to celebrate the end of the mHealth Fairview Sanford merger attempt. Right? Big thank you to the Minnesota Nurses Association and the University of Minnesota med students who educated, agitated, and organized to stop that awful merger from happening. In the early 90s, a study was done in Minnesota that demonstrated how HMOs and managed care were not working when it comes to decreasing health disparities. But the study was never published. The Star Tribune article stated that the study had been shelved because the HMOs complained about it. Managed care ideology is actually exacerbating disparities, particularly racial health disparities. We cannot effectively address disparities and inequity until we change the financing of our system. After half a century of screwing around with managed care theories, you'd think we'd have solid evidence of an epidemic of overuse. Well, we don't. And for the small pockets of overuse that do exist, we have no evidence that they are caused by this fee-for-service system, and yet we keep implementing these goofy incremental changes. One of the latest iterations of managed care tactics is called ACOs, Accountable Care Organizations. I'm sure some of you have heard of those. And they are infiltrating both the federal and state public health programs. So what are they? Well, let me quote. When Congress passed the Affordable Care Act, it envisioned doctors and hospitals joining forces, coordinating care, and holding down costs. Now, 8 months into the new law, there is a growing frenzy of mergers involving hospitals, clinics, and doctor groups. So decreasing cost? Not so much. Even a CMS contractor couldn't explain how ACOs were supposed to reduce overuse, stating it's a financial arrangement wherein provider organizations attempt to reduce expenditures below a set target while maintaining high-quality metrics in exchange for bearing risk for reducing expenditures. What? I mean, what? Okay, so they don't decrease costs, but surely they improve quality. Studies of the impact of the Medicare Shared Savings Program on quality have produced mixed findings. Some have found small improvements on a few quality measures. Other studies have found no impacts on quality metrics studied or slight worsening of quality. So much for improving quality. And one more trick they had up their sleeve, these value-based payments. That sounds logical. I mean, who doesn't want to pay for quality, right? That seems to make sense. Well, the American Association of Family Physicians defines value-based payments as follows. Value-based payments uses alternative payment models or pay-for-performance arrangements to create a combination of incentives and disincentives intended to encourage better healthcare decision-making by tying compensation to certain performance measures. So, if the care provider can care for you for less than the specified amount that they get, they share in the savings. If the care that they provide exceeds that amount, they're penalized. Who thinks using perverse incentives is a good way to deliver health care? That doesn't make any sense at all. Healthcare costs are high because prices are high. A 2014 Lancet article stated prices rather than volume of health services contribute the most to explaining the higher U.S. spending. Hospital charges are higher, procedures cost more, prescription drugs are considerably more. You couple that with the enormous waste within our system due to all this fragmentation and complexity that creates unnecessary administrative costs as high as 34%. That's 34 cents of every healthcare dollar. And the answer to why healthcare costs as much as it does, it's pretty easy to figure it out. And if these market-based fixes are failing, why do we keep implementing them? Good question. One explanation is because the medical industrial complex is as powerful as they are. It's no different than the bank robber Willie Sutton's explanation when he was asked why he robs banks. He said, because that's where the money is. Our public health programs, Medicare and Medicaid, are now a major source of revenue and profit for insurance companies. In fact, public programs are the only material source of growth potential for insurers, given that employer-sponsored insurance has been largely stagnant. Recently, Humana announced that it is going to exit the employer market and focus solely on playing in Medicare and Medicaid. And all this privatization is seriously affecting the political dynamics of debate over Medicare and Medicaid policies. As private insurance companies increasingly rely on public health insurance programs, their ability to grow and be profitable could depend as much on their lobbying muscle in Washington and in state capitals as on their market prowess and the value that they provide to enrollees. As we celebrate Medicare and Medicaid's 58th birthday, we need to be deeply concerned about what's happening to these life-saving programs because the higher costs generated by this continued privatization of Medicare and Medicaid will be financed by everyone, and that includes the non-elderly. A single-payer system, improved Medicare for all, or the Minnesota Health Plan will guarantee health care for everyone through a publicly financed system that provides comprehensive benefits and a single standard of care. Healthcare decisions are made by patients and their caregivers, not by a corporation or government bureaucrat, ensuring scarce health resources are not squandered by profiteers, marketing, and excessive administrative costs. Right? So I want to pull this all together by reading a blog that was written by a Minnesota nurse, an M&A nurse, Emily Priscala, during the peak of the COVID-19 pandemic because it explicitly lays out why we are in this movement with each other and why we simply cannot give up in our fight for healthcare justice. Emily wrote, "If I die, I don't want to be remembered as a hero. I want my death to make you angry too. I want you to politicize my death. I want you to use it as fuel to demand change in this industry, to demand protection, living wages, and safe working conditions for nurses and all workers. Use my death to mobilize others. Use my name at the bargaining table. Use my name to shame those who have profited or failed to act, leaving us to clean up the mess. Don't say heaven has gained an angel. Tell them negligence and greed has murdered a person for choosing a career dedicated to compassion and service." The time, right? Powerful. The time is now. Let's deprivatize, improve, and expand Medicare to all, no exception, and let's center our public health around our common humanity. Si se puede, brothers and sisters.